Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 402 of our pharmacotherapy series, which majors in upper gastrointestinal disorders. The next clinical case reads: SPC is a 71-year-old retired man who was eating dinner with his wife when he experienced a sudden onset of chest pain described as crushing, burning, and squeezing. His wife notified emergency personnel, who transported SPC to the emergency department. His past medical history reveals some cardiovascular risk factors, including age, hypertension, hyperlipidemia, and a sedentary lifestyle. His medications before admission include aspirin 81 mg daily, hydrochlorothiazide 25 mg daily, and atorvastatin 40 mg at bedtime. He also takes over-the-counter famotidine 20 mg daily as needed for dyspepsia. On examination, he complains of substernal crushing chest pain that has lasted more than 1 hour. He is diaphoretic and extremely anxious. He denies any shortness of breath, pain radiating to upper extremities or jaw, or cough. His vital signs include a temperature of 99.1 degrees Fahrenheit, blood pressure of 155 systolic 95 diastolic, and heart rate of 115 beats per minute. His pertinent laboratory results at this time are as listed below. White blood cell, WBC, count, 7,700 per microliter. A hemoglobin of 14.2 grams per deciliter. A hematocrit of 45%. Platelets of 270,000 per microliter. A serum creatinine of 1.1 mg per deciliter. A BUN of 11 mg per deciliter. Total cholesterol, 161 mg per deciliter. Low-density lipoprotein, of 93 mg per deciliter. High-density lipoprotein, of 30 mg per deciliter. Triglycerides, 190 mg per deciliter. Serum sodium levels of 141 milliequivalents per liter. Serum potassium levels of 4.1 milliequivalents per liter. Troponin I levels of 0.3 nanograms per milliliter. Electrocardiogram reveals sinus tachycardia with no evidence of ST segment elevation, depression, or TWAVE inversion or new left bundle branch block. Because of SPC's cardiovascular risk factors and indeterminate troponin, he underwent immediate diagnostic cardiac catheterization, which showed normal coronary angiography and an ejection fraction of 65%. SPC was diagnosed with NonCardiac chest pain, abbreviated as NCCP. So my question to you reads: could SPC's chest pain be associated with an extraesophageal manifestation of gastroesophageal reflux disease? Extraesophageal, that is, atypical, manifestations of gastroesophageal reflux disease are those signs and symptoms that occur outside of the esophagus yet are presumed to be associated with gastroesophageal reflux disease. The extraesophageal manifestations of gastroesophageal reflux disease include NCCP, pulmonary symptoms, and complaints related to the ear, nose, and throat, as well as hypersalivation and dental erosions. Interestingly, these symptoms are often the only complaint that a patient has when he or she presents to the healthcare provider. Let's briefly look at non-cardiac chest pain. About 30% of patients with angina-like chest pain have normal coronary arteries or minimal microvascular disease as demonstrated by cardiac angiography. Up to 60% of these patients will have concomitant gastroesophageal reflux disease as demonstrated by an abnormal esophageal endoscopy or ambulatory pH monitoring. The symptoms associated with non-cardiac chest pain, abbreviated as NCCP, are very similar to those associated with cardiac angina. The chest pain is usually described as crushing, squeezing, or burning, retrosternal in location, and with or without lateral radiation to the upper extremities, back, neck, or jaw. The pain is often temporarily related to a meal or occurs nocturnally, usually awakening the patient and continuing for hours. An appropriate workup for coronary artery disease must be performed in all patients presenting with chest pain before considering a gastrointestinal cause or trial of anti-reflux therapy. This is especially important in women, the elderly, and diabetic patients, because their initial presentation may be similar to gastrointestinal complaints when in fact an acute coronary syndrome is present. Numerous trials have evaluated the use of acid suppression as a means to treat non-cardiac chest pain once cardiac etiology has been ruled out through appropriate evaluation. Meta-analyses and guidelines have suggested the proton pump inhibitor test, in which a short course, that is 4 weeks, of high dose, that is twice daily, proton pump inhibitor is used, is an effective diagnostic tool and is associated with a reduction in costs compared with other diagnostic methods of gastroesophageal reflux disease. We will now consider asthma and gastroesophageal reflux disease. Reports suggest that concomitant gastroesophageal reflux disease occurs in up to 80% of the asthmatic population through 2 theoretical mechanisms that might work to exacerbate asthma symptoms. One is the vagal reflex theory, which proposes that symptoms result from the direct irritation of the vagus nerve when refluxate comes into contact with the esophageal mucosa, resulting in reflex bronchospasm. In contrast, the microaspiration or reflux theory proposes that aspiration of refluxed acid into the lungs causes caustic injury of tissue within the bronchial tree, resulting in asthmatic symptoms. Significant controversy exists regarding the benefit of anti-reflux pharmacotherapy in patients with asthma, especially in those patients who do not endorse typical gastroesophageal reflux disease symptoms. An important meta-analysis of trials that evaluated the effects of anti-reflux therapy on patients with asthma indicates that asthma symptoms improved in 69% of patients, that the use of asthma medications was reduced by 62%, and that only 26% of the subjects showed improvement in evening peak expiratory flow rate. All other pulmonary function tests showed little or no change with anti-reflux therapy. However, this meta-analysis only evaluated studies of up to 8 weeks in duration. A large randomized, double-blind trial evaluated esomeprazole 40 mg twice daily versus placebo for 6 months in patients with poorly controlled asthma managed with inhaled corticosteroids, who lacked typical gastroesophageal reflux disease symptoms. Results revealed no benefit in asthma control with the addition of a proton pump inhibitor, despite 40% of subjects demonstrating gastroesophageal reflux disease by ambulatory pH monitoring. Current American Thoracic Society, European Respiratory Society guidelines for the management of severe asthma suggest that gastroesophageal reflux disease and anti-reflux therapy can be considered in patients with poorly controlled asthma, if they have gastrointestinal symptoms consistent with gastroesophageal reflux disease. The American Gastroenterological Association position statement accepts the use of an empiric trial of twice-daily proton pump inhibitor for asthmatic patients with typical gastroesophageal reflux disease symptoms, but that reflux monitoring should be considered before proton pump inhibitor trial in asthmatic patients with atypical gastroesophageal reflux disease symptoms. Let's briefly look at otolaryngology symptoms and gastroesophageal reflux disease. Gastroesophageal reflux disease is the most common etiologic factor in 60% of patients with chronic laryngitis and in 25% to 50% of patients with a globus sensation, the feeling that something is caught in the throat. Symptoms relating to gastroesophageal reflux disease are responsible for up to 10% of the patients seen by otolaryngologists. The most likely mechanism for the pathophysiology of gastroesophageal reflux disease-related laryngitis is that damage and inflammation occur at night while the patient is sleeping. It is during this time when upper esophageal sphincter pressures are especially low and the protective or neutralizing mechanisms of cough and salivation are suppressed. This damage may be in addition to injury or laryngeal inflammations sustained from other causes, such as excessive voice usage, smoking, chronic throat clearing or cough, vomiting, or injury from endotracheal tubes. The extent of injury in gastroesophageal reflux disease-related hoarseness is directly related to the exposure time of the pharyngeal mucosa to the refluxate as well as the pH. Patients with gastroesophageal reflux disease-related hoarseness usually do not have any other gastroesophageal reflux disease-related symptoms. The diagnostic procedure of choice is laryngoscopy and should be considered in all patients presenting with gastroesophageal reflux disease-related hoarseness. Once the diagnosis of gastroesophageal reflux disease-related hoarseness or laryngitis is established, the patient will likely require extended high-dose proton pump inhibitor therapy with the understanding that the majority of patients will relapse within 6 weeks once therapy is discontinued. And now let's look at treatment for the extraesophageal manifestations of gastroesophageal reflux disease. Experts suggest that treatment should be initiated with a high dose, that is twice daily, proton pump inhibitor for at least 3 months before considering drug therapy to be ineffective. However, data are lacking to support this recommendation with the exception of non-cardiac chest pain. Recent guidelines suggest this empiric strategy is acceptable if concurrent typical gastroesophageal reflux disease symptoms are present. Alternatively, it is possible that gastroesophageal reflux disease may not be the cause of the patient's symptoms. SPC's chest pain is not of cardiac origin based on angiographic findings. Therefore, it is reasonable to presume that he is having an extraesophageal manifestation of gastroesophageal reflux disease. SPC's symptoms were meal-related, and he has a history of dyspepsia for which he takes an over-the-counter histamine 2 receptor antagonist. The histamine 2 receptor antagonist should be discontinued, and SPC should be given a trial of empiric twice-daily proton pump inhibitor therapy for a period of 2 to 4 weeks. If symptoms are severe, the use of endoscopy, to determine if esophageal damage is present, or 24-hour esophageal pH monitoring, to correlate reflux events with symptomatic chest pain, is appropriate. SPC responded well to the trial of omeprazole 40 mg orally twice daily and has not had chest pain in 2 months. He has heard that surgical options exist that may eliminate his need for medications, as they are very expensive for him. So my next question to you reads: is SPC a candidate for anti-reflux surgery? Numerous surgical and endoscopic procedures exist for patients with gastroesophageal reflux disease. These include, but are not limited to, Nissen fundoplication, Toupet partial fundoplication, Belsey Mark IV repair, and the Hill posterior gastropexy repair, as well as newer endoscopic techniques. The primary goal of these procedures is to restore lower esophageal sphincter pressure by repairing a hiatal hernia or diaphragmatic hiatus. Appropriate candidates include patients who are in a good health and request another treatment option as a result of poor medication adherence, patients who are unable to afford their medication, patients who suffer from side effects or worry about risks with long-term therapy, patients with extraesophageal symptoms who have responded well to antireflux therapy, or patients experiencing volume regurgitation and aspiration of gastric contents who have not responded to proton pump inhibitor therapy. Despite the availability of these surgical options, the consideration of anti-reflux surgery is one in which the benefits should be heavily weighed against the risks of such an invasive approach, because these procedures are not without potential complications. The effectiveness of these procedures has been questioned, because many patients will still require drug therapy. SPC has responded well to high-dose proton pump inhibitor therapy for his NCCP, but he describes some financial difficulties with affording his medications. Alternatively, he is 64 years of age, which may increase the risk associated with surgery. SPC should be referred for further medical evaluation to determine whether he is a candidate for anti-reflux surgery. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arora, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 403.